In this lecture, we'll be talking about angina and how to treat angina. We'll talk about what angina is and the different types of angina, and then we'll talk about three classes of drugs used to treat it: nitrates, beta blockers, and calcium channel blockers. So let's discuss different types of angina. First, I want to clarify the pronunciation. It is pronounced angina, not angina. Angina is basically transient episodes of sudden severe squeezing or pressing substernal chest pain that radiates to the neck, the jaw, the back, and sometimes the arms, typically the left arm. It's classically described as feeling like an elephant is sitting on the chest, and patients will say, it feels like a heavy pressure or real tightness in the chest. Sometimes patients will say it's a discomfort rather than a pain. They'll say, I don't have any pain, but it's just hurting. And I always thought, well, if it's hurting, that means it's pain. But there's a distinction there that it's a severe discomfort without necessarily typical pain. It usually lasts more than a few seconds. And if patients tell you, I'm having sharp pain just for a few seconds here and there, you can reassure them that's not likely to be angina. Angina is often associated with dyspnea or shortness of breath, nausea, and often diaphoresis or sweating as well. And there's a sign that's important to know, and that is Levine's sign, where a patient will make a fist to indicate this squeezing or tightness in their chest, and they'll put that fist right on top of their chest. Usually it's with the right arm because the left arm is painful. Angina is caused by insufficient cardiac oxygen supply. That is, its oxygen supply is not sufficient to match the demand for oxygen. This is classically related to coronary atherosclerosis. It can also be due to vasospasm or anemia or other things that can cause a lower oxygen supply to the myocardium. And generally with angina, we're talking about transient myocardial ischemia without myocardial infarction or cell death. So there are three different types of angina we'll talk about. The first is stable angina. This is the most common. This is sometimes referred to as typical angina because it's the typical presentation. This is angina that's precipitated by some type of activity: running, walking, climbing stairs. And they're usually minimal or no symptoms at rest. The symptoms typically abate several minutes after you stop that activity or stop that exercise. And then when you start exercising again, the activity resumes. So this is stable, it's predictable, it always has the same pattern. Usually it's relieved by nitroglycerin or other vasodilators. Patients will say, I'm always able to climb one flight of stairs, but if I climb that second flight of stairs, I'm going to start getting that pressure in my chest. So stable angina or typical angina is predictable. Generally, it's caused by a reduction in coronary perfusion due to a fixed restriction or fixed obstruction because of atherosclerosis of the coronary arteries. Usually more than 75% stenosis is required to cause stable angina symptoms. The myocardium is vulnerable to ischemia whenever there's an increased oxygen demand from physical activity or sometimes from emotional excitement. If you have a small amount of coronary obstruction or coronary stenosis, those coronaries are able to dilate and overcome that stenosis and overcome that restricted oxygen demand or oxygen supply. But if you have a larger amount of stenosis, 75% or more, when that activity or that emotional state increases heart rate, increases myocardial oxygen demand, the coronaries are not able to compensate for that. Also with stable angina, there will be ST depression on the EKG. And this is what we're looking for when we do a cardiac stress test. We'll hook a patient up to an EKG and then make them walk on a treadmill. Usually they go through different stages on the treadmill, a little more increased speed, a little more incline on the treadmill, trying to increase the myocardial oxygen demand, increasing the work of the heart. And we'll watch for ST segment depression on that EKG. And that's an indication of some myocardial ischemia going on. The next type of angina to discuss is unstable angina, and this is angina that changes or worsens. This can include new onset angina within the last 4 to 6 weeks. A patient who never had any kind of chest pain now finds that when they climb those 2 or 3 flights of stairs they're getting chest pain. Even though that may turn out to be a predictable thing, at first it's a change, so that is unstable angina by definition. Any kind of angina that is becoming more severe or more frequent, or it's occurring at a new threshold, meaning the patient used to be able to climb 3 flights of stairs, and now they find that climbing that first flight of stairs is causing angina symptoms. That is unstable angina by definition. And there may be angina at rest or with minimal exertion. Usually this angina is going to last more than 10 minutes or so. Now, unstable angina is different in the cause of it, different than stable angina. Unstable angina is really considered a form of acute coronary syndrome. You can imagine a spectrum of acute coronary syndromes where on one end you have stable angina, a fixed obstruction, a predictable pattern of angina. On the other end of the spectrum you have full-blown myocardial infarction. Unstable angina is somewhere in the middle. It's more severe, it's more dangerous, more worrisome than stable angina, but it's not as worrisome as an MI. Unstable angina can be a serious indicator of an impending MI, and very often these patients will be hospitalized and watched very closely to make sure that they're not getting ready to have a big myocardial infarction. Now, I mentioned there's a difference in the pathophysiology between stable and unstable angina. In unstable angina, there's not a fixed coronary obstruction. What you have is a transient reduction in coronary flow, either from transient platelet aggregation on the surface, on the endothelial surface of the coronaries. The endothelial surface may seem healthy, but there is some platelet aggregation for whatever reason, and that causes a transient obstruction. The body's natural thrombolytic system will break up that platelet aggregation, and the obstruction will pass, and the blood flow is restored, and so the pain resolves. The other thing that can cause unstable angina would be coronary thrombosis, where you have a plaque that ruptures, and that disturbance in the endothelial surface allows platelets to start to aggregate there and cause a thrombus, and that will disrupt downstream coronary flow. The difference between this type of unstable angina and a full-blown MI is that with the unstable angina, the clot is lysed before you can get myocardial necrosis. So the lack of myocardial necrosis is the proof of this event being simply unstable angina due to thrombosis rather than a full-blown MI. Unfortunately, you don't have the opportunity to cut open the patient's heart and look at it under the microscope, so you can't tell clinically what's going on while it's going on. Typically with unstable angina, the symptoms may not be relieved with nitroglycerin, not relieved as well as it would be with stable angina. And on EKG, you're going to see ST depression again. The other type of angina to discuss very briefly is called Prinzmetal's angina, or variant angina, sometimes vasospastic angina. This is relatively uncommon. It's a form of episodic angina caused by coronary artery spasm. So the artery spasms, that reduces myocardial oxygen supply, reduces myocardial blood flow or coronary blood flow, and therefore you start to get myocardial ischemia and you get the typical anginal pain. This is more common in younger patients, maybe patients in their 30s or 40s who get some vasospasm. These episodes usually relieve themselves within 20 minutes or so. Patients can have some evidence of coronary atherosclerosis, but the angina attacks are unrelated to that atherosclerosis, and they're unrelated to physical activity or increases in heart rate or blood pressure. So that's what makes this different from unstable angina, is that you're not going to precipitate this with activity. This is precipitated entirely on its own by vasospasm of the coronary arteries. And on EKG, you're not going to see ST depression, rather you're going to see ST elevation. ST elevation is generally thought of as indicating more advanced myocardial ischemia. So if you have more ischemia because of severe vasospasm, you can actually see ST elevation with Prinzmetal's angina. Remember, we talked about ST depression with the other forms of angina. That's because there's mild ischemia. If that ST depression progresses from ST depression into ST elevation, then you will potentially be having a myocardial infarction, which is more advanced. So the more ischemia you have, first the ST segment will depress and then it will become elevated. Sometimes we see mixed forms of angina in which patients will have advanced coronary disease and then they get angina episodes both at rest and with effort. So they have a fixed obstruction causing some stable angina symptoms with exertion, and then they'll also have symptoms at rest due to unstable angina and some endothelial dysfunction. So let's get into the treatment of angina. Before we talk about drug therapy, let's briefly discuss options for non-pharmacological therapy. One of the most important is lifestyle modification and risk factor modification. So the things that cause an increased risk of MI, an increased risk of atherosclerotic disease, are things like hypertension, hyperlipidemia, diabetes, sedentary lifestyle or inactivity, obesity. So if you can modify those things through pharmacotherapy or through lifestyle modification, wonderful. So you need to reduce risk factors. The other risk factor I didn't mention, the big one, smoking. If you can reduce a patient's smoking or get them to quit smoking, you can often reverse some of their atherosclerosis and reverse the angina process altogether. Other non-pharmacological therapy includes PTCA, which stands for percutaneous transluminal coronary angioplasty, and that's most commonly done with stenting of the artery. First, you do an angiogram, which takes a picture of the luminal diameter of the coronaries. You insert a catheter into the femoral artery, pass the catheter up through the aorta to the coronary arteries, and then you inject IV contrast into the coronary arteries so you can see stenosis or narrowing of the artery. To perform an angioplasty, you then insert a wire and a balloon through that stenotic lesion, then inflate the balloon with saline so that the balloon forces open the area of stenosis. Then sometimes you'll put an expandable wire mesh tube called a stent over the balloon, and when you inflate the balloon, you expand the stent. When you withdraw the balloon and the catheter, the stent stays in place and holds the stenotic area open. The third form of non-pharmacological therapy worth mentioning for coronary atherosclerosis is coronary artery bypass grafting, or CABG, C-A-B-G, we pronounce that cabbage. A coronary artery bypass graft is a vein, usually taken from the patient's leg. You create a graft that diverts blood around the stenosis. So you're literally allowing blood to bypass the stenotic lesion. Or sometimes, instead of using a vein, you'll use the internal mammary artery, which already has arterial blood supply, and you connect it distal to the stenosis. Now let's talk about drugs used to treat angina. As I mentioned, there are three classes of drugs: nitrates, beta blockers, and calcium channel blockers. And all three of these classes lower oxygen demand by affecting blood pressure, venous return, heart rate, and contractility. The first group of drugs is the organic nitrates. There are lots of different nitrates that we use. Nitroglycerin is the most common one. We use isosorbide dinitrate, isosorbide mononitrate, amyl nitrate. There's another nitrate listed, sodium nitroprusside. It's usually used for hypertensive emergencies rather than for angina, but we'll mention it here because it is a nitrate. It works the same as the other nitrates. The primary action of nitrates is venous dilation. So you're decreasing the preload, you're allowing the veins in the body to dilate, so the blood will pool in the veins, and it increases venous capacitance, so there's less blood returning to the heart, and that decreases the preload that the heart is seeing. Because you have decreased preload, the heart doesn't have to work as hard, so you have decreased myocardial oxygen consumption. Nitrates will also cause a little bit of arterial dilation, especially in the coronary arteries, but that's really a minor mechanism compared to the venodilation. So remember that. That's a great PIMP question on the wards. An attending will ask you, well, how do nitrates work? Why are the nitrates improving this patient's angina? It has nothing to do, or has very little to do, with coronary dilation. It has much more to do with reduced preload due to venodilation. So the mechanism of action of nitrates, nitrates are converted to nitrite ions, and the nitrite ions are then converted to nitric oxide. And nitric oxide is an important vasodilator in the body. Nitric oxide activates guanylyl cyclase, which is the enzyme that converts GTP into cyclic GMP, and then that ultimately leads to dephosphorylation of the myosin light chain in the smooth muscles of the vessels. So the smooth muscle relaxes, the vessels relax, and you have vasodilation. So let's talk about pharmacokinetics. The onset of action of nitrates can be very rapid, nitroglycerin begins to work within a minute, or it can be very long. Isosorbide mononitrate may take up to an hour to work or more. Nitrates are generally extensively metabolized by the liver using first-pass hepatic metabolism. This means that those drugs are not really useful when given orally. So sometimes we'll give them sublingually. Nitroglycerin can be given as a tablet, and very often heart patients will carry around a little jar of nitroglycerin tablets, and whenever they get angina, they'll slip one under their tongue and let it dissolve. There's also nitroglycerin spray, which is used usually in the emergency room. You spray under the patient's tongue, and that it can be absorbed that way. We also use transdermal delivery of nitroglycerin. There's nitroglycerin patches for ongoing routine use, and there's nitroglycerin paste, which is usually put on in the emergency room. You'll write an order to apply 1 inch of nitro paste to a patient's chest to help relieve the angina. The exception to this rule is isosorbide mononitrate, which is stable against hepatic breakdown, so you have improved bioavailability and a longer duration of action. So you can give this drug orally, and it will be used long term. Isosorbide dinitrate is actually absorbed orally, and then it's broken down into 2 molecules of isosorbide mononitrate, and both of those possess anginal activity. So the isosorbide dinitrate and mononitrate can be given orally, but nitroglycerin cannot be given orally. You'll also sometimes see IV nitroglycerin used. As I mentioned, nitroprusside is used to lower the blood pressure rapidly, not really used for angina. The adverse effects of nitrates, very important. Headache is the most common side effect of all nitrates. Up to 60% of patients can have headache with long-acting nitrate drugs. Nitrates will also lower the blood pressure. They're causing venous pooling of blood, so you have lower blood pressure, so you can get postural hypotension. Patients will have their blood pool in their lower extremities, and then when they stand up quickly after being supine or sitting for a while, they'll get very lightheaded and dizzy. So watch for postural hypotension. They can get facial flushing. They can get reflex tachycardia. Their blood pressure is dropping, so their heart's going to speed up to compensate for that. And this is especially a problem at higher doses. It's important to know that the drug sildenafil, or Viagra, as you've probably heard it called, will potentiate the action of nitrates. So in patients who are on nitrates, they cannot use any of the phosphodiesterase inhibitors for erectile dysfunction. It can cause very dangerous hypotension. At high doses, nitroglycerin can also cause methemoglobinemia, which can lead to cyanosis and hypoxemia. This can also be a problem with amyl nitrate, but it's not a problem with isosorbide dinitrate and isosorbide mononitrate. Tolerance to nitrates develops very rapidly. The blood vessels simply become desensitized to the effects of the nitric oxide. Patients who, or rather factory workers who used to work in facilities where they use nitroglycerin or manufactured nitroglycerin, used to have what they call Monday morning headaches. They'd go to work, their body had become accustomed to the nitrates throughout the day and the work week. Then they're off for the weekend, and their bodies become desensitized, or rather sensitized to nitrates again. Then they go to work on Monday morning, and they get this dose of nitrates. They get vasodilation from the nitrates, and they start to get headaches because they become sensitized over the weekend and desensitized during the work week. Tolerance to nitrates is overcome by providing a nitrate-free interval to restore the body's sensitivity to the nitrates. Typically it takes 10 to 12 hours to become resensitized to it, and usually what we'll do is we'll tell the patients who, if they're using a long-term nitrate, such as an oral isosorbide mononitrate or dinitrate, they'll take the drug in the morning, and then overnight it'll kind of wash out of their body, so they become resensitized to the nitrate. If you have a patient who's got a nitroglycerin patch, we'll write the order for the patch to be put on for 12 hours and then taken off for 12 hours, so they get a 12-hour nitrate-free period. Or when you write that order for the nitroglycerin paste to be put on the patient's chest, you'll write an order to wipe it off and leave them nitrate-free for a certain period of time. Now, Prinzmetal's angina usually worsens early in the morning, so you want to time the nitrate-free interval maybe late in the afternoon so that you can give them the nitrates early in the morning when they're going to need it, or allow them to have their nitrate before they go to bed so that they don't wake up at 4 a.m. with angina. And then any patient who continues to have angina despite nitrate therapy is usually a candidate for another class of drug. You can add other drugs to the nitrates, but nitrates are generally the first-line treatment for angina.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide.
Do nitrates treat angina primarily by dilating coronary arteries or by dilating peripheral veins? They do improve coronary circulation, but the main mode of action is peripheral venous dilation, which causes peripheral pooling of blood and reduced preload, which reduces myocardial oxygen demand. Wipe that disinterested look off your face and pay attention. If I'm boring you, maybe you'd like to lead the team's rounds today.
Okay, let's go through quick review number 1. True or false? Nitrates relieve symptoms of cardiac ischemia by dilating coronary vasculature. This was mentioned in the lecture. Of course, this is false. So in the event of cardiac ischemia, coronary vasculature is already maximally dilated. If you have tissue that's starving, one of the ways the tissue is going to respond is by releasing local metabolites. It's going to maximally dilate the vasculature so that it can get more oxygen and relieve the hypoxia. So in the event of cardiac ischemia, so long as you're not talking about Prince-Meadows angina, the coronary vasculature is already maximally dilated. So what do nitrates do? They dilate venous circulation, and in doing so, they reduce your preload, and by reducing preload, they reduce myocardial oxygen demand, which means that those ischemic heart cells don't need as much oxygen, so it doesn't matter that they can't receive as much. The symptoms of hypoxia, the hypoxia is relieved by way of decreasing the need for oxygen, not by delivering more oxygen. Number 2, which category of medications are contraindicated when a patient has been prescribed nitrates? This also was mentioned in your lecture. It's the phosphodiesterase inhibitors that in particularly are used for erectile dysfunctions. These drugs are easily identified because they end in a "-phil". This is sildenafil, which is Viagra, vardenafil, which is Levitra, and tadalafil, which is Cialis. So a scenario that you might imagine here is a patient taking a drug for erectile dysfunction, then engaging in intercourse, which can be an exertional activity, and then as they're exerting themselves and exercising themselves, maybe they start to have some chest pain because their heart can't take all that exercise. And so those patients might then reach for their nitroglycerin, take their nitroglycerin, and now they have 2 medications on board that are going to open up the venous circulation and cause decrease in blood pressure. So you're going to have a dangerously low blood pressure, severe hypotension with a combination of those 2. So as a result, any patient that has been prescribed nitroglycerin cannot be on these drugs, these phosphodiesterase inhibitors. Whether or not they're taking it, if they have a bottle of nitroglycerin, don't give them phosphodiesterase inhibitors. Number 3, what are the different forms of nitrates that can be given to a patient suffering with unstable angina in the emergency room? So usually you're going to see different forms of nitrates given based on the severity of the patient's symptoms and the likelihood that they're having an MI. So if you have a younger patient where the likelihood that their chest pain is due to MI, but you want to give them some type of nitrate, you're just going to give them some sublingual nitroglycerin. Patients with a moderate likelihood of MI, you're probably going to slap on some nitropase, like an inch of nitropase. If you have proof of MI or their patient has a very high likelihood of MI, usually you're going to give IV nitroglycerin in that case. So this is a little clinical pearl for you. Additionally, if the patient has an ongoing chronic need for nitroglycerin, you're going to use isosorbide mononitrate or isosorbide dinitrate. Instead of just giving it as needed, this is a long-acting nitroglycerin. Number 4, why do many physicians prefer to prescribe sublingual nitro spray to patients rather than sublingual tablets? the spray has a longer shelf life. So maybe you've seen with those sublingual nitroglycerin tablets, they're in a little brown bottle because they're easily degraded by UV light. So those tablets have a much shorter shelf life than the spray. So you might have a patient reaching for their nitroglycerin tablet and taking it, but it's expired. With the spray, that's less likely to happen. Number 5, in patients needing long-term daily nitroglycerin treatment, what is usually the preferred agent? This goes back to what we just mentioned a second ago. This is isosorbide mononitrate. Isosorbide mononitrate can be dosed once daily versus isosorbide dinitrate, which has to be dosed 2 or 3 times a day. And of course, sublingual nitroglycerin is taken as needed. So if you need a chronic daily treatment of nitroglycerin, go for isosorbide mononitrate. Number 6, what is methemoglobin? So methemoglobin was mentioned in the lecture. This is the oxidized form of hemoglobin. So with methemoglobin, the iron molecule, instead of being in this normal 2+ ferrous state, it's in a 3+ ferric state. And as a result, this iron molecule cannot bind oxygen as readily, and this can lead to hypoxia, which is why methemoglobin is so problematic. The next question, or the next component of question number 6, which anti-anginal medications can cause methemoglobinemia? This can be caused by nitrites. Nitrites, but not nitrates. All right, so this is kind of one of those little known facts. It's in some pharm books, not in other books. So while nitroglycerin, like sublingual nitroglycerin or IV nitroglycerin, can cause methemoglobinemia, isosorbide dinitrate will not cause methemoglobinemia. And then the last component of this question, what is the treatment for methemoglobinemia? The treatment is pretty easy to remember because it's methylene blue. METH for methemoglobin, METH for methylene blue. Also, vitamin C can be given for its antioxidants effect because you're having problems with oxidating hemoglobin, so it makes sense to give an antioxidant, right? Number 7, at the cellular level, by what mechanism do nitrates relieve angina? So this is important to know, highly testable. They are converted to nitric oxide, which increases cyclic GMP, which leads to dephosphorylation of myosin light chain. This results in vascular smooth muscle relaxation and vasodilation, and again, preferentially in the venous side of circulation rather than the arterial side. Number 8, a patient is in the ER for suspected myocardial infarction, and 1 inch of nitropase is placed on his anterior chest wall. What is the most likely complaint this patient will have in 30 minutes? Classic throbbing headache. So these patients are going to get headache because you're vasodilating the coronary vasculature, the meningeal vasculature, and they're going to get a throbbing headache as a result. So you can expect this, and it's not a big deal.
So as I mentioned, there are 2 classes of drugs that we typically use in addition to nitrates. The first of these are the beta blockers. Now there are lots and lots of beta blockers out there, but we're only going to talk about the ones that are most often used for angina. And these include propranolol, which is sort of the prototype beta blocker, and then also atenolol and metoprolol. There's a 4th drug mentioned in Lippincott's, which is acebutolol, which is actually not indicated for angina, and some sources will say that it's contraindicated for angina. That's because in addition to being a beta blocker, it also has some intrinsic sympathomimetic activity. It can actually agonize certain beta receptors. So it should not be used for angina. It is indicated for hypertension and arrhythmias, but just not for angina. So the mechanism of action of beta blockers is that they're antagonists of the beta adrenergic receptors. And there's a whole chapter on beta adrenergic receptors, or adrenergic antagonists in general. And that's chapter 6 of Lippincott's. We have a whole lecture on that. So if you want more details on the beta blockers, you can look at those resources. Some beta blockers, such as propranolol, are non-selective, meaning they block both beta 1 and beta 2 receptors. Some of the newer beta blockers, including atenolol and metoprolol, are more cardioselective. They're more selective for beta 1 receptors. But they often lose selectivity at higher doses. So if you give a high dose of atenolol or a high dose of metoprolol, you can get some beta 2 blockade. The actions of beta blockers, they reduce heart rate, they reduce blood pressure, they reduce contractility, and all of this is going to lower myocardial oxygen demand. As far as therapeutic uses, They are used for angina, often in conjunction with nitrates, as we mentioned. All patients with ischemic heart disease should be on a beta blocker, which beta blockers have been proven to reduce the incidence of further MI and reduce the incidence of acute coronary syndromes. They also reduce mortality following MI. So all patients with any ischemic heart disease really need to be on a beta blocker, whether or not they're having anginal symptoms. Beta blockers are used for congestive heart failure. Beta blockers are used for hypertension. Beta blockers are sometimes used for tachyarrhythmias and to suppress palpitations. Beta blockers are also used for lots of non-cardiovascular indications, such as treatment of migraines, treatment of tremors. Sometimes they're used for patients with some type of social anxiety or stage fright. Performers will sometimes take a little propranolol to help calm their nerves and reduce the jitteriness they get before they go on stage. So lots and lots of uses for beta blockers. As far as pharmacokinetics, these are oral drugs. The half-lives are usually around 4 to 6 hours for all these compounds, so they have to be given twice a day. There are some extended release versions of metoprolol and some of the other beta blockers that are available. Other pharmacokinetic considerations: propranolol readily crosses the blood-brain barrier and can cause some CNS effects. Propranolol is also extensively metabolized by the liver using first-pass metabolism. Atenolol, on the other hand, does not cross the blood-brain barrier, and it is almost 100% renally excreted. So if you have a patient with liver disease, you're going to put them on propranolol or atenolol. Well, atenolol, because if they have liver disease, the propranolol is going to stay around in their body a lot longer. Metoprolol is metabolized by the liver and then excreted by the kidneys, so it has a little bit of both. In terms of adverse effects, they're used for hypertension, and they can cause some hypotension. They also slow the heart rate, so they can cause some bradycardia, so patients need to be warned of that. Sometimes beta blockers can precipitate arrhythmias if you stop them too quickly. So it's generally recommended that you taper off of beta blockers over 5 to 10 days, maybe a week on average. Long-term treatment with a beta blocker will actually upregulate the beta receptors, so you'll get more beta receptors on cells because they're trying to get some kind of beta agonism going on. So when you stop therapy, those patients have lots of beta receptors out there, and they're going to be much more responsive to their own intrinsic beta agonists, such as epinephrine and norepinephrine. So you can have increased angina and increased hypertension immediately following cessation of a beta blocker. So that's one of the reasons that you taper off slowly. Beta blockers can also cause some bronchoconstriction. Now, this is typically more of a problem with propranolol and some of the other non-selective beta blockers. But even the cardioselective beta blockers can cause some bronchoconstriction if you give enough. So if you get high dose, you are going to get some beta 2 antagonism and some bronchoconstriction related to that. Now, because the older beta blockers, such as propranolol, were non-selective and they were potentially fatal in patients with asthma and COPD, tend to think all beta blockers are contraindicated in any patient with asthma. And I would certainly never, ever recommend giving propranolol or any non-selective beta blocker to an asthmatic patient. But some of these newer drugs, atenolol, metoprolol, have been demonstrated to be pretty safe for patients with asthma. So you can get away with it. You just need to use it cautiously and warn patients that if they start to get shortness of breath, if they're having increased symptoms, wheezing, cough, that kind of thing, then you may need to stop the beta blocker. Now, because beta blockers cause some hypotension, because they cause some bradycardia, patients will often complain of some fatigue when you first start the drugs. You need to warn them that for the first 3 days they may feel a little run down and tired, but I usually tell patients after those first 3 days you should be back to normal. So if you're still feeling excessively tired or fatigued after a week of being on the drug, you need to come back in and check. Maybe they've got severe bradycardia, maybe their heart rate's 35, in which case you need to stop the beta blocker. Beta blockers also commonly cause sexual impairment in men. It's not really clear why, but a lot of men who are put on a beta blocker will complain of some erectile dysfunction. It is pretty clear that both hypertension and atherosclerosis are independent risk factors for erectile dysfunction, so it may be that we're just unmasking some pre-existing disease by starting a drug which may exacerbate that a little bit. But sexual impairment is a big problem for men in this age group. You know, men in their 50s and 60s are starting to notice a little erectile dysfunction, and if you give them a drug that's going to make that worse, they're not going to be very happy with you. So you need to warn your patients about it, and if there's a problem with it, you may need to come off of the drug. Or sometimes just start with a small dose and titrate up to the maximum tolerated dose. Finally, beta blockers can cause some disturbances in metabolism. Beta blockers cause decrease in glycogenolysis and a decrease in glucagon secretion. So what is this going to do to blood sugar? Well, you're going to lower blood sugar. So beta blockers can potentially lower blood sugar and sometimes can cause fasting hypoglycemia. Also, beta blockers can block the symptoms of hypoglycemia. So those symptoms of hypoglycemia are sympathetically mediated. So you're going to get some tachycardia and that kind of thing. So a patient who is on a beta blocker may not have that tachycardia. They may not feel the hypoglycemic symptoms. So if you have a patient who's diabetic, who's on some therapy that might cause hypoglycemia, such as insulin, sulfonylureas, you need to be aware that giving a beta blocker may decrease the chance that they're going to feel their hypoglycemia, which can be potentially life-threatening. Diabetes itself doesn't cause hypoglycemia, but a lot of the medications can. So again, you have to use caution in giving a patient with diabetes a beta blocker, but you can use them. You just need to be aware of the risks involved. Beta blockers can also cause dyslipidemia. Specifically, they can raise triglycerides and lower HDL. So the last category of drugs we're going to talk about then are the calcium channel blockers. And there are two main types of calcium channel blockers, the dihydropyridines and the non-dihydropyridines. The dihydropyridines include nifedipine, amlodipine, isradipine, nicardipine, nisoldipine. There's a drug called felodipine, which is less commonly used for angina. There are about 24 different calcium channel blockers. Not all of them are available in the United States, but there are lots and lots of calcium channel blockers. But the ones that we use most commonly for angina are the dihydropyridines. These have a much greater affinity for the vascular calcium channels than for calcium channels in the heart, and we'll talk about exactly what that means in a moment. The other type of calcium channel blockers are the non-dihydropyridines. So there's verapamil, which is much more selective for heart calcium channels. It has a little bit of effect on vascular calcium channels, but it's much more selective for the cardiac calcium channels. And another type of non-dihydropyridine, diltiazem, which is sort of in between verapamil and the dihydropyridines. It has some effect on the cardiac calcium channels and some effect on the vascular calcium channels. Because the non-dihydropyridines act on the cardiac calcium channels, they're less commonly used for angina, but the dihydropyridines are more commonly used for angina. The mechanism of action of calcium channel blockers is very important. Calcium, the intracellular levels of calcium are critical for regulation of smooth muscle contraction and in contraction of the myocardial cells. So when calcium enters the muscle cells, it enters through a special voltage-gated calcium channel, and that influx of calcium triggers a release of more calcium that's already being stored in the cell, in the mitochondria and the sarcoplasmic reticulum. So you get an increase in calcium that's triggered by opening of this voltage-gated calcium channel. So the calcium channel blockers are going to block these L-type calcium channels, these voltage-gated calcium channels, in the arteries, in the smooth muscle arteries, both in the coronary arteries and the peripheral arteries. And that blockade of the smooth muscle causes those vascular tissues to relax and dilate. So mainly, calcium channel blockers are dilating arterioles. Blockade of the same calcium channels, these slow voltage-gated calcium channels in the heart, causes reduction of contractility, which is what we call a negative inotropic effect. So less strong muscle contraction because there's less calcium, which is really important in muscle contraction. It also slows conduction and automaticity of the conduction pathways of the heart. So that's what we call a negative chronotropic effect. So you have slower heart rate because of calcium channel blockade. Both of these effects, the negative inotropic effect and the negative chronotropic effect, can reduce myocardial oxygen demand, which may help angina. Now, which drugs do we say are going to affect both the heart and the blood vessels? Those are the non-dihydropyridines, so the diltiazem and verapamil. So these drugs, because they're acting in the heart, they can cause some bradycardia, and they can also worsen congestive heart failure because they're depressing myocardial contractility. Dihydropyridines are more selective for the vasculature, so you're going to get vasodilation without a lot of bradycardia and without as much negative inotropic effect. Let's talk about some therapeutic uses of calcium channel blockers in general. For angina, when we're treating Prinzmetal's angina or variant angina, we typically reach for a dihydropyridine. Now think about it, why would we want to use a dihydropyridine for Prinzmetal's angina? Well, Prinzmetal's angina is caused by vasospasm, as we said. So the dihydropyridines are acting more on the vessels than the heart, so they're going to dilate the coronary arteries and reduce the vasospasm. Sometimes non-dihydropyridines can dilate arteries as well, as we said. So sometimes non-dihydropyridines can be used for Prinzmetal's angina, but generally it's the dihydropyridines that we use. Now, since the dihydropyridines are also going to cause peripheral vasodilation, we can also use the dihydropyridines for stable angina. We wouldn't really reach for verapamil for stable angina because you have to get a pretty high dose of verapamil in order to get any vascular calcium channel blockade. Remember that stable angina occurs when myocardial oxygen supply is lower than demand. So if we dilate the peripheral arteries, we reduce afterload, and that puts less demand on the heart. The heart doesn't need as much oxygen, so you can get you get more bang for your buck. The oxygen that's already being supplied is adequate to meet that reduced oxygen demand. Calcium channel blockers are also widely used in the treatment of hypertension. Calcium channel blockers are sometimes used to treat tachyarrhythmias like atrial fibrillation. Now again, think for a moment, which type of calcium channel blocker would you want to use for a tachycardia? Well, you're going to reach for one of the non-dihydropyridines, either verapamil or diltiazem, because those drugs are more selective for the cardiac calcium channels. They're going to cause some bradycardia. Sometimes calcium channel blockers are used for migraine prophylaxis or prophylaxis of other types of headache syndromes, such as cluster headaches. Sometimes calcium channel blockers like verapamil are used to treat other vasospastic conditions like Raynaud's phenomenon. The pharmacokinetics of calcium channel blockers, these are all oral drugs, but some of them can be given intravenously, especially diltiazem and verapamil and nicardipine. Most of them have pretty short half-lives, 3 to 8 hours, so they sometimes have to be given twice or 3 times a day. Most of these do have a sustained release formulation available, so you can get away with giving them once a day if that's what you're looking for. And generally we try to go once a day, have a long, continuous action for patients with angina rather than short-acting drugs. It's generally recommended not to use short-acting calcium channel blockers in the treatment of angina because when the calcium channel blocker wears off, the angina is going to come right back. So you want to give something that's going to be used continuously or be available continuously. One calcium channel blocker, it's worth noting, has a long half-life, and that's amlodipine. Its half-life is more than a day, so you don't have to give twice daily amlodipine. There is no sustained release formulation. The drug is naturally sort of a sustained release because it has a long half-life. And all the calcium channel blockers are metabolized in the liver and then excreted. So let's talk about the adverse effects of calcium channel blockers. These drugs are used to treat hypertension, so they can cause some hypotension. And as a result of that, they can cause some lightheadedness and dizziness and also fatigue. You can sometimes get reflex tachycardia, especially with the dihydropyridines, because again, the non-dihydropyridines are going to slow the heart rate down a little bit. But if you give a dihydropyridine, you're going to lower blood pressure, and the heart's going to respond to that by reflexively increasing the heart rate. So you can get reflex tachycardia. Calcium channel blockers will cause vasodilation and lead to headache, just like the nitrates did. The non-dihydropyridines can cause bradycardia, so that's an important side effect to be aware of. For some reason, all calcium channel blockers tend to cause fluid retention and peripheral edema. And this is a big problem, especially in patients who have congestive heart failure, because those patients are sensitive to fluid overload. So if you give them a calcium channel blocker, that could be really dangerous. You can actually precipitate decompensation of their heart failure. So you want to avoid calcium channel blockers in patients with congestive heart failure. Also, these drugs tend to have negative inotropic effects, as we mentioned. They're going to reduce myocardial contractility, and that's a bad thing for someone who already has impaired myocardial contractility. So remember, do not use calcium channel blockers in patients with congestive heart failure. And then finally, most calcium channel blockers can cause some constipation. So you need to be aware of that, because that's not necessarily dangerous to a patient, but it can be very uncomfortable. And a lot of patients will be on 2 or 3 different drugs that cause constipation, and so it may be an additive effect. Maybe none of these drugs by themselves will cause the patient to have constipation, but when you add 2 or 3 different drugs that are all constipating, you can get a real problem. So finally, before we finish, on page 213 of Lippincott's, there's a figure that shows why you might choose one class of drug over another in a patient with angina based on what other diseases they have. No patient has angina by itself. Usually the patient will have risk factors, as we mentioned, such as ischemic heart disease, hypertension, congestive heart failure. Very often patients were smokers, and that's why they have coronary disease, so they also have some COPD. So as you look at this figure, it's probably easiest to look at it and figure out which classes are not used in certain situations. So as we mentioned, we want to avoid beta blockers in patients with asthma and COPD, or at least use them with extreme caution. Why is that? It's because beta-2 blockade will cause bronchoconstriction. So you need to be careful in patients with pulmonary disease. You also want to avoid beta blockers in patients with diabetes. We talked about that. And why is that? It's because beta blockers can cause hypoglycemia, and they can also mask symptoms of hypoglycemia. If you have a patient with a recent MI, you probably do want to put them on a beta blocker. As I mentioned, beta blockers will reduce mortality following an MI, and all patients with ischemic heart disease need to be on a beta blocker, so that's important to know. Generally, we don't give calcium channel blockers to patients who have recently had an MI. Why is that? Well, studies have shown that short-acting calcium channel blockers like nifedipine may actually increase mortality following an MI. Early on, in the first week following an MI. Later on, by 6 months, there's no real change in mortality. This may be due to repeated episodes of hypotension, which leads to reflex sympathetic activation, and this is not a problem with long-acting calcium channel blockers. Now, verapamil and diltiazem may be beneficial in select patients following an MI, especially if they have a non-Q-wave MI, that's a non-ST elevation MI, and if they have no pulmonary edema. In congestive heart failure, calcium channel blockers are a problem because of reduced contractility and edema. And then finally, if you have a patient with hypertension and angina, calcium channel blocker or a beta blocker would be a good choice because these drugs are going to lower the blood pressure. You're actually treating hypertension, which is one of the risk factors of atherosclerosis, which is causing angina in the first place.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide.
Which drug cannot be used in combination with nitrates because of the risk of hypotension? Oh, I know, sildenafil. You might know this as Viagra, which is used to treat erectile dysfunction. You know, I always thought that ED was the male version of a headache. Don't those women have anything better to do?
Who let her get drunk again during lunch?
So let's go through the answers to quick review number 2. Number 1, what are the common adverse effects of beta blockers? These are definitely important to know. You have hypotension and bradycardia, bronchoconstriction, fatigue, sexual dysfunction, hypoglycemia, and dyslipidemia. And it's important also to know that in the treatment of glaucoma, sometimes you're going to use beta blocker eye drops rather than taking it orally. Even those eye drops can cause hypotension and bradycardia and the resultant syncope that can result from those things. So that's also something to be aware of. Number 2, why might using a non-selective beta blocker be detrimental in vasospastic or Prince-Metal's angina? So beta-2 blockade does not allow vasodilation in the coronary arteries and leaves unopposed alpha receptors which worsen vasospastic angina. So that's something worth knowing. You have your alpha receptors that are vasoconstricting, your beta-2 receptors vasodilate. When you give a beta blocker, you get rid of the beta-2 vasodilation. All you're left with is the alpha vasoconstriction. Number 3, which beta blockers are the only ones with proven to reduce morbidity and mortality after an MI? These are metoprolol and carvedilol. So while the other beta blockers might be useful in treating angina, if you have a patient that's had a history of an MI or is having an MI, then the only beta blockers they should be on are either metoprolol or carvedilol. Number 4, what suffix is common to the dihydropyridine calcium channel blockers? This is just a hint for you guys. This is dipine, D-I-P-I-N-E, like amlodipine, nifedipine, nicardipine. If you see dipine at the end of a drug name, it's probably a dihydropyridine calcium channel blocker. Number 5, how do dihydropyridines relieve angina symptoms differently in patients with Prince metals angina as compared to those with stable angina? So in Prince metals, the dihydropyridines cause dilation of the coronary vasculature. And in stable angina, the dihydropyridines work more like your nitrates do. They cause a peripheral vasodilation, resulting in decreased preload, which results in decreased myocardial oxygen demand. So 2 different mechanisms for the same drug in treating 2 different illnesses. Number 6, why might a physician choose to combine a beta blocker with a dihydropyridine calcium channel blocker? So when the dihydropyridines cause vasodilation, that's going to decrease your blood pressure, decrease preload in the heart, and the heart is going to respond by increasing the heart rate. This is called a reflexive tachycardia. And if you, and of course, when your heart rate increases, that's increasing your myocardial oxygen demand. So if you want to lower blood pressure without causing reflexive tachycardia, you can combine a beta blocker with the dihydropyridines, which is going to keep your heart rate low while also lowering your blood pressure. So by giving a beta blocker, you can prevent this reflexive tachycardia. Number 7, what are the common adverse effects of calcium channel blockers? So both the dihydropyridines and the non-dihydropyridines like verapamil can cause reduced blood pressure, which can result in lightheadedness, and dizziness, syncope, and fatigue. Both categories of calcium channel blockers can also cause peripheral edema and cause a CHF exacerbation, heart failure exacerbation, and both categories can also cause constipation. The dihydropyridines can cause a reflexive tachycardia versus the non-dihydropyridine like verapamil and diltiazem can cause bradycardia. Also, your verapamil and diltiazem, your non-dihydropyridines, can cause a heart block, an AV heart block, like a first-degree heart block where you're prolonging the PR interval, or a second-degree heart block where you're dropping a QRS. Number 8, what are some of the various uses of dihydropyridine calcium channel blockers? They're used in hypertension, obviously, and one thing that I think is worth knowing is these drugs are used in pregnancy. So this is a safe antihypertensive in pregnancy, are your dihydropyridine calcium channel blockers like nifedipine. These drugs we also saw are used in the treatment of Prince metals angina. They can also be used for Raynaud's phenomenon, where you have vasoconstriction in cold environments, specifically in your fingers. So these drugs can be helpful in treating that. And because they're relaxing smooth muscles, these drugs can also be used in cases of esophageal spasm. So they can relieve esophageal spasm as well. If you have something lodged in a patient's esophagus and you want to try to relax the esophagus to dislodge the item, sometimes you might reach for one of these drugs to help you do that. Number 9, what is the primary use for verapamil? So diltiazem we said was kind of the hybrid between verapamil and the dihydropyridines. Diltiazem works at the heart. Diltiazem also works at the smooth muscles. So that one is used to treat hypertension, but verapamil in particular is going to be your go-to for tachyarrhythmias. So if you have atrial fibrillation with a rapid ventricular rate, you're probably going to reach for either a beta blocker or verapamil in that case. And then number 10, what is the most important thing to remember in treating tachycardia? Very important to know. first identify what's causing the tachycardia, right? You don't want to just throw verapamil into a patient not knowing why they're tachycardic in the first place. What if they're tachycardic because they're dehydrated? What if they're tachycardic because they have a sepsis, because they have an infection that's causing tachycardia? Always identify the cause of tachycardia before you treat it. So tachycardia, again, can be caused by dehydration, can be caused by infection, can be caused by hypoxia, can be caused by, it could be medication-induced, like you would get with a reflexive tachycardia due to dihydropyridines, or it could be a tachyarrhythmia. And if it's a tachyarrhythmia, like atrial fibrillation with rapid ventricular rate, then you're going to reach for your verapamil. Okay, so now's a good time to pause the video and complete your in-session quiz, then restart the video and we'll go through the quiz together.
Hello, welcome to the in-session quiz for the Antianginal Pharmacology lecture. My name is Dr. Chris Lewis. I'm one of the DIT Chief Educators. Let's get started. Sort the following drugs by drug class. The drugs in question are nitroglycerin, atenolol, nifedipine, diltiazem, metoprolol, and verapamil. Under organic nitrates, the only medication there is nitroglycerin. Under calcium channel blockers, the three medicines are nifedipine, diltiazem, and verapamil. And under the beta blockers, the only two left are atenolol and metoprolol. Match the drug class to its mechanism of action or major effect. Calcium channel blockers. Well, they are arteriolar vasodilators that cause a decrease in vascular resistance. The nitrates relax veins to decrease preload and myocardial oxygen demand. And beta blockers reduce heart rate, they reduce blood pressure, and they reduce myocardial contractility. Which classes of antianginal drug are typically used for Prinzmetal's angina? Well, these are the vasodilators, which include dihydropyridine, calcium channel blockers, and the nitrates. Next, what is the most common adverse effect of nitrates? This is headache. Of the three beta blockers discussed in this lecture, which one is non-selective? Well, that's the original beta blocker, propranolol. Give two reasons that calcium channel blockers are contraindicated in patients with congestive heart failure. Well, the calcium channel blockers will reduce myocardial contractility, and they also cause edema and fluid retention. These are the exact problems that can make congestive heart failure worse. People with congestive heart failure will have problems with contractility with their heart, and they'll have fluid accumulation already. Therefore, you certainly don't want to make that worse. Next, match the following calcium channel blockers with the correct characteristic. Nifedipine has a greater effect on the peripheral vasculature. Verapamil will mainly work on the myocardium, and the diltiazem has an intermediate action, has a little bit of both. Which is more responsible for the antianginal effects of nitrates? Coronary artery dilation or venous dilation? Well, this has been said several times during lecture. It's venous dilation and reduced preload. Do calcium channel blockers typically reduce preload or afterload? Well, they typically dilate arteries, which reduces afterload. What effect does beta blockade have on serum glucose? It can reduce blood glucose and lead to fasting hypoglycemia. This doesn't happen very often, but it's something to keep in mind. More importantly, they can block the sympathetically mediated symptoms of hypoglycemia. When people get hypoglycemic, they get jittery, they get sweaty, their heart will race a little bit. And if you're on a beta blocker, those things tend not to happen. Therefore, people can have a masked hypoglycemia and not know it. And that's your in-session quiz for the antianginal drug.